Good morning, everyone, and welcome to our session about utilising NLP and clean language to improve patient outcomes. I'm Andy Coley, and I run Beyond Training Solutions with Joe here. You've probably seen us about on the stands and just generally about. I'm really pleased to be here presenting something at the conference. I'm slightly less pleased that it's the morning after the NLP Awards, but it'll be fine. And also we're joined by Raki Shah. Raki will explain all about herself in a bit, but Raki's done her Master Practitioner with us, and one of the reasons why Joe and Raki in particular will be presenting this is because it's something that really is part of what we do as a business, and in particular what Raki does with patients when she's working with them in healthcare. So without further ado, I'm going to hand over to the guys, and they're going to take you through the journey.
So I'm Joe. So the purpose of today really is to give you an understanding of how we utilise the NLP and clean language skills and how we combine them and help people, help clinicians and health professionals utilise them when they're working with patients to improve patient outcomes. And I suppose the key is, the key way to improve patient outcomes is for the patient to take ownership of their own health outcomes. And I think that is something that probably people kind of know and yet don't really necessarily always take on board. Just before we start, can I just do a quick room check? How many of you work within health? How many of you already? Yeah, okay. Of those, how many work within the NHS? Okay, all right, so probably half of you working within the NHS. I'll just give you a little bit of background in terms of what we do and kind of why we do it. So we work with a lot within the healthcare arena, a lot within the NHS, and also with other clinicians outside of the NHS. And we work both with them as an individual basis. So as Andy was saying, Raki's done her Master Practitioner with us, and the key is for us is, okay, how do you utilise what you're learning with your NLP skills and be able to apply it within the health environment to improve those patient outcomes. And we also go into both health and commercial organisations and utilise the skills of NLP and clean language within what they do for a variety of things, partly to get the team kind of really understanding the culture that they need to operate within, but also teaching some of the key skills to improve the patient outcome side of things. So, you know, why do we do that? For me, in terms of my background, I've been running Beyond Training Solutions with Andy now for nearly 5-6 years now. Before that, I did work in the NHS. I'm not a clinician, just so you're all aware. I had a really good title, Business Excellence Director. How about that? That's a good title, isn't it? Partly my role was I worked in Hertfordshire. I worked for a really big GP practice, primary care practice. We had 21,500 patients, and my role was to kind of look at, okay, outside of the clinical side, what are the processes and what are the development cycles that need to happen in order to improve the outcomes within the surgery I was working with, and also with all the surgeries within Hertfordshire. And you know, I left working with the health service because I recognised that I wanted to use the skills that I had to be able to kind of make more of a difference outside of that. But my big why was to do with this gentleman. The reason I recognised that, my big push, my big driver, was when I lost my dad. So this picture here was on the last outing that we took Dad on. We went to Norfolk Broads with him and had a really amazing day. Now, you know, Dad at that time was a little bit jittery, he'd had a couple of strokes, he'd recovered reasonably well, but you know, his memory was going a little bit. Very strong, very independent person, you know, very analytical, very logical, was an accountant. Yeah, always, you know, Dad liked things. He was very much the guy that, you know, lunch on the table at 1:30, you know, dinner on the table at 5:30 type thing, liked things in a very sort of structured way. Very determined, though, very, very determined guy. In the September of the year previously to us losing him, he had an episode that they thought was another stroke, and he was taken into hospital. During the 3.5 weeks that he was in hospital, he deteriorated fairly rapidly, actually. And suddenly he was kind of going from this quite independent guy to somebody who his personality started to really change. He became quite aggressive. His mobility deteriorated fairly quickly. He was fairly active, walked a bit with a stick. Suddenly he was having to use a Zimmer frame and couldn't get around. But his personality was changing. He was becoming sort of more aggressive, a bit more confused. And we didn't really know why and what was happening. They said it was probable that he'd had another stroke, but he was still undergoing tests. And I remember going to the hospital after the 3.5 weeks, 5 o'clock in the evening, and they sat down, a social worker came to see us, and she said, okay, they've looked at your dad's where he is now. Yeah, he doesn't need to have a hospital bed. We kind of need to discharge him, so we need to discharge him tomorrow. So he'll be coming out of hospital tomorrow. Now, we had constantly said to Dad, to the people that were working on the ward, that one of our real challenges as we sort of started to see the deterioration with Dad was that we were in the process of moving Mum and Dad closer to me so I could help. And basically their bungalow they're moving into was a shell. And we'd had that conversation with them a lot of times because I was talking about what modifications, what adaptations do we need to put in place in the shell. And yet at 5 o'clock, they told me they were discharging him the following day. So at 5 o'clock, I had to, and they told me that that was okay. They could put him into a residential home for a period of time, but it could be anywhere. It could be anywhere within Essex or the surrounding counties. So I had to go about finding, very quickly a place for Dad that we then had to fund. So that was kind of that bit. And I kind of realised, well, hang on a minute, they haven't heard me, they haven't listened. Dad went home, he went to a residential home, and once the bungalow was ready, he came home. He was actually only home for 10 days, but that was possibly the longest 10 days of our lives. Because during that 10 days, the home care that he had, to be really honest, was pretty abysmal. We had things like him laying in his own urine for 2.5 hours because there'd been a miscommunication and the carers hadn't turned up. His mobility was starting to go downhill a bit, and it kind of accumulated. The whole episode of him being at home was when he had a fall from the chair, and the carer, doing what they thought was best, used a hoist belt to get him up. And what they did was they put the hoist belt around here, and they stood behind him because they couldn't lift him, and they pulled him up using the belt. The result of that was that at 11:30 that night, we believe the result of that was Dad started vomiting blood. And Dad was taken into hospital. Dad never came back home again. Over that next 4.5 months, Dad deteriorated really, really quickly. And it was quite interesting going from walking in and seeing Dad fairly mobile to the next morning walking in and seeing Dad being lifted in just a nappy on a hoist. And through that whole period, there was loads of things. All the things that you kind of read about in the paper. Things like walking in, finding his medication amongst his sheets. Him not getting the nutrition that he needed. But the biggest problem that was happening was we didn't understand what the hell was going on. We really didn't understand what was going on. After 2 weeks, we were told that he hadn't come in for vomiting blood because his notes had got lost. And there was loads and loads of things, and we were like, can someone please explain to us? And no one could. And what we also recognised was that nobody was listening to Dad in terms of what Dad wanted. We lost Dad in the February of the following year. And it was, to be honest, it was pretty awful. And I was angry, really, really angry for a period of time. And then I stopped and stepped back, and I recognised two things. I recognised that every single one of those health professionals, whether it was the caregivers at home, the people within hospitals, the consultants, the whatever, nurses, whoever it was, they were absolutely, without fail, doing the best that they could do with the resources that I had available to them. And when we talk about resources, most of you have done your NLP, and we're talking about the internal resources, but also the external resources, the physical resources that were around them. And I kind of thought to myself, okay, if I step back, how can I do something, and working with the experience and knowledge we had, to help on that? But the other key thing that I recognised was that the thing that was lacking, the biggest thing that would have made a difference, was communication. And yet, the one thing, the one area that probably has the least investment in terms of training within the NHS, definitely, is communication. There's a lot, there's more and more investment. Funds are lacking. The way that the emphasis is on the clinical side of things and the clinical skills. But if you look at that whole thing around human factors and how that affects safety and how that affects patient care, one of the biggest things is communication. So how can we utilise what we know and our own experiences to make a difference? For us, the key on making that difference is being able to work with both the organisations but also the individuals that make a difference. So we encourage our practitioners, our master practitioners, and those people that come into our training to really, really think about, actually, how can I use this stuff? How can I really use it to make a difference to what I do? And we work with people, as Andy was saying, people like Raki, in ordering them to give them the skills to be able to do that. So Raki, I don't know, do you want to explain a little bit about you and what you do and why you're kind of up here?
Yeah, sure. Hello everybody. It's a real honour and a real pleasure to be here today to share just a little bit about what I do and who I am. So my name is Raki. I am a specialist podiatrist in diabetes. So what that means is that I work with people that have diabetes and on the area where you start getting long limb complications, so problems in the long limbs. So that's my field of work. So when I was qualified as a podiatrist, there was a number of areas that I could have gone into. So there was surgery, there was biomechanics, there was a variety of areas I could specialise in. However, whenever I looked into the field of diabetes, I always heard amputations, loss of life, the devastation that diabetes can cause for people, and in particular, losing a limb, the effect and the impact that happens. Anybody that has an amputation, the life expectancy is pretty poor post-amputation. Most people die within 5 years of a limb amputation of some sort. The survival rate post-amputation is probably comparable to some of the cancers, and in particular colorectal cancer. So I realised that, if I can do something of some impact, I want to help people with diabetes and in this particular field. I saw a few people during that time, and I was able to spot things, well, actually, why are we doing it like this? Why can't we do it like that? Why are we doing it like this? And that sort of really gave me a lot of passion, that I want to work with people to stop patients, not only patients, but their family members. So every time a patient goes through something, I recognise that so does the husband, so does the wife, so does the children, so does the extended family, and so do we as practitioners. Every time I see a patient and we go through things together, and that really drives me to try and make a difference in some way that I can make a difference. So that's my main reason for being sort of within the diabetes field in this particular field. But I also recognise that I may have all these clinical tools. I'm very hands-on clinical, so I use a lot of stuff. So be it dressings, be it blades, be it scalpel handles. My room's like an operating theatre sometimes. I have so much stuff that I can use in terms of tools. But sometimes I realise that, there's some tools that I'm just missing. Something's missing, and I just didn't know what it was. And something inside me was telling me that something's missing. I can give you an example where I had a lady and we worked really well together. It was a really, really successful situation where we healed some lower limb ulcers, and I was super chuffed because I thought, brilliant, she's now not going to turn into that ratio of a person that has an amputation. Excellent, well done, Raki, good, good, good. So she came to one of my appointments and she's healed up nicely, and I was like really passionate and stuff. I said to her, now the next step is, we need to get you out of these semi-permanent shoes, and we need to get you into some permanent shoes. So here's a catalogue, and these are the shoes, and these are the colours, and this is the width, and then the depth, and you can choose these varieties, and they're really, really good. And she was lovely. She went, yeah. Took the catalogue and put it into the handbag and left. So, me at lunchtime thinking, and I was telling all my colleagues how wonderful the situation was and how pleased I was. Saw her at a next appointment and nothing's really changed. So I thought, well maybe she lost the catalogue. Or maybe I didn't explain it well enough. Or maybe she just missed something, so I did it all over again. Got the same catalogue out, this is the catalogue, we need to now move you from these shoes into these shoes, and that will stop your ulcers coming back, which is what we want, isn't it? And I went through it all over again, and she went, yeah, super, yeah. Put the catalogue in her bag and walked out. Okay, and I thought, okay, we've done that twice now, so, surely by now, we should be getting somewhere. So, I saw her again the third time, and nothing's changed. And it really stopped me in my track. I was like, well, I'm keeping this lady's catalogue, and I'm definitely, I'm done it twice, I'm definitely giving the catalogue. I've told her about the will. I've said everything, I've done it all. Why? So in the bafflement that was going on in the back of my mind, I sort of didn't touch on the conversation quite as much. And at the end of the consultation, she grabbed my hand and she goes, Raki, do you know what? She says, I know how much you care about me, and I absolutely know how much I do need to change the shoes that I am, so we don't end up with the problems that I've had. But she goes, you know what, Raki? She goes, my fridge freezer broke several months ago, and I'm saving up for a fridge freezer. So what I'm doing is I'm putting all my food into a bag, and I'm putting it in a box, and I'm putting it in the landing, because there's nowhere else cold enough that I can store that food. But she goes, Raki, do you know what? I really do promise you, the minute I get a fridge freezer, after I've done that, shoes are the next thing on my list. And at the time, I was like, whoa. Because I realised I hadn't taken the time, the opportunity, hadn't had maybe the right language tools, or really thought of it from her perspective. What's going on for her in her world? In her world, she hasn't got a fridge freezer. She's storing food in a bag on a landing somewhere, trying to just get by. So in reality, fridge freezer versus food and storage versus shoes, it's really quite an obvious choice. But I recognised that I maybe hadn't done enough to understand her map of the world and what's going on for her, and therefore work together to work out what the next steps were for us together for her. And it really made me realise that I'm clearly missing something along the line. And that's one of the things that I think I've learned from the training that I've had with Joanne, is to recognise, I have my map of stuff that I think needs to happen, but every single person is an individual that walks into my clinic, and they too have their world that's going on for them. And how, therefore, can I work better with them to make things happen? So the example I can give you is a lovely lady that one of my admin raved to me a couple of weeks ago and said, oh gosh, we're just struggling with the Raki, we're really struggling with it. I said, well, what do you mean? I said, look, she just always wants to change her appointment. She never wants to keep her appointment. Whatever appointment we give her, she just rings up and changes it. I said, okay. So this particular lady, I was aware of, and I knew a little bit about it. I said, okay, well, I'll speak to her. So this is now post-training. And so I rang her up and said, oh, you know, hi, you know, it's Raki, you know, how are you getting on? You know, what's going on? You know, I believe you've been ringing to change your appointments quite a few times. And knowing now what I know, I said, well, you know, how can we work together? Because for me, my purpose isn't to see that person today and end of story. For me, my purpose is to maintain a long-term relationship with that individual and that patient, so that I can do and I can make the biggest impact to that person's life. If I'm not working with them, I've lost them. And I recognise that that's one of my biggest purposes. I want to maintain a long-term relationship with these people. So I said, well, look, well, what can we do? What can, you know, how can we work things together? You know, what's going on? And I asked some questions, and it basically what transpired is that what was happening was the girls were given a particular appointment on a particular day at a particular time, and it kept clashing with her prayer meeting. So she wanted to go to a prayer meeting. And she goes, well, every time you give me an appointment on that day, she goes, it clashes with my prayer meeting. She goes, it's not that I don't want to come and see you. I want to come and see you, I really do. It's just this time doesn't work for me. So therefore, we just adjusted it. I said, well, okay, well, I'll take you off that particular list, and I'll put you on a slightly different list. You'll still be with me, just a different time, different location, different section of the clinical list. But I know that, you know that, we know that, and that's absolutely fine. I said to the admin girls, like, you know, let's just work it like this. This works for us, and that's it. So for me, some of the things that I've learned by doing this training and applying it, even peppering it is what I sometimes call it. I don't have to make big tidal changes, just little drops of bits here and there in my work has just helped me become much more an effective clinician. And so therefore the patients that come and see me, I hope, are getting a much better service. And what I can help them with, it's just changes more. So that's my version of what I do.
And it's really interesting, you know, listening to Raki talking about peppering it and not making, you know, sweeping changes all the time. For us, that was something that, you know, that we realised. By the way, if anybody wants to ask questions or anything, I didn't make that clear at the beginning. If you want to interrupt us to ask questions, just do. I'm happy to expand. You know, it can be really, you know, when you get a new set of skills, whatever they are, you kind of want to go out there and give them to everybody and say, you need to be doing this. But one of the things, having worked with clinicians for nearly 7 years myself, and also continuing to work with clinicians and health professionals through what we were doing, was I kind of recognised that every single clinician works in different ways, and also depending on the areas that you work in, you all have different challenges and demands. Those of you who work within the NHS, there's definitely different challenges and demands, and goalposts continuously moving, and 1 minute this is the priority and the next minute this is the priority, etc. So us going out and saying you need to do it like this is a wonderful new way, you know, all that's doing really is putting more pressure and more stress. So it was okay, how do we utilise and allow, I suppose really it's making it easier. How do we actually make the life of the clinician and health professional easier in order for them to kind of get it and therefore enable the patient to take more ownership of their own health outcomes? And one of the light bulbs for me was about 3 years ago. We were approached by a GP, and she was really passionate about utilising motivational interviewing. Does anybody use motivational interviewing framework within what they do? Yes, she was really, really passionate about that. But what she recognised was no matter how much she kept telling people that you need to do this and you need to get training on this, and she worked at Imperial College and she was a lecturer there, people kind of weren't doing it because it was quite difficult, yeah, and quite a lot to learn. And in fact, people were coming out the 2-day initial motivational interview and going, yeah, it's really, really interesting, but I don't know quite how to use it. So we started to work with her and the Diabetes Association to look at ways that you can kind of make it easier. And what's great is actually there's a joint venture with 5 of the commissioning groups within London, and they've actually taken our work into the diabetes guidelines. So that is really great, but we kind of realised that actually it was how do we make it easier for you to utilise what you already know. So we started to look at some of the models that were out there and started talking to clinicians in terms of how you work and what you do and what's going to make it easier. One of the examples, for example, is working with the heroin intervention categories. So I'll go through this fairly quickly because some of you may already know this, but basically this was a comprehensive model of the different ways, the different styles of being able to consult. Whether you're a doctor or a therapist or whatever you are, so we kind of looked at it. And basically, you know, there's 6 areas. There's the prescriptive, give them advice, tell them how to do it. There's the informative, well, it's giving your view and your experience. There's the confronting, way. There's the cathartic, help them express their feelings of fears and getting those feelings out there. There's the catalytic, asking questions to encourage the fresh thinking, and they're supportive, you know, really telling them what a good job. And quite, you know, very often, I'm sure you'll recognise, you probably move between those naturally during what you do. So, from your knowledge and from the way you work, you know, rather than us just constantly talking to you, just to get you kind of, you know, discussing and thinking, maybe just for a couple of minutes, just have a little chat in pairs. What do you think? We look at a GP. Let's take it for a scenario of a GP working within the NHS, bearing in mind that the GP has 10 minutes to do their consultation, including getting their history and doing everything else. What do you think is the most effective one of those intervention styles for the GP to use? So if we just give you a couple of minutes, just have a little bit of chat and then we'll feedback. Okay, so what do you reckon? What do you think is the most effective one? More particularly when we're talking about, you know, getting patients to take ownership and you know, getting that making a difference. What do you reckon? Anyone?
Depends on the patient, what they come in.
Yeah. Okay, so what they come in the door with depends on the patient. Everyone agree it depends on the patient, or anybody got a different view? Okay. And
I was quite. I mean, I hooked into the 10 minutes bit. And so there's an ideal and there's an actuality. And so it's probably prescriptive.
Probably prescriptive, yeah.
I thought actually it's cathartic help for 10 minutes, and the reason I thought that was because you can talk to the patient as much as you like, telling them what you should be doing. But based on what she was saying, if they've got holding this stuff inside them, you can talk to them until you're doing the face, you can talk to them for half an hour, you can talk to them for an hour. If they've got the fear, they will, like your clients do, they will say, oh, thank you, yes, and I'll do it, whatever, and go away, and they've still got their life in the world.
Yeah.
So although it sounds peculiar for 10 minutes, you're going for really where the person is at.
Okay. Okay, any other views on that?
Problem with empathy, which we're all trained to give. Sometimes you give that empathy, the patient goes away, comes back in, gets more empathy, goes away, and they come back in for the empathy. And actually, you need that, for certainly diabetes, you need to be catalytic to get into the other side of that problem. It's easy things, it's, don't try to do this or don't do that. Or need some information about how not to do that. Sometimes you have to confront, so you have to do all of them. I think catalytic is probably how you get the patient to see outside of their problem into a solution, and you don't do it early on.
So we picked one or two, so whether it's this or it's that, and then actually came to that conclusion that people said, which is what have they come in for, and the most effectiveness is what's motivating them to be there, which is how one would respond. So it's not necessarily any one of those, it could be any number of those.
It was really interesting when I first looked at this, because I looked at it, we talked about maps, I looked at it from my map, and so what would I like? If I was walking into a GP, what works best for me? Yeah, you go prescriptive with me. Start telling me what to do. No way.
That's not just in healthcare, by the way.
But having spoken to a large number of clinicians and talked to them about, okay, what are their challenges, whether it's in the workshops we do or individual stuff that we do, is that recognising it does very much depend, and it very much depends on what they're coming in for clinically, but also where they are. Most of you, are NLP trained in some way. So if we just look at their meta programs, it kind of depends, doesn't it? Yeah. If we look at the way they're filtering, it kind of depends. If we look at their drivers, what's important to them, it kind of depends. If we look at, we're going to talk about this a bit later, where they're holding, that issue that they have, that health issue they have, in terms of, you know, the neurological levels, it kind of depends. You know, if you look at, also there's so much else around outside of that. Age, experience, expectations. You know, my mum, yeah, bless her, she wants prescriptive or informative. Yeah? And no matter what the doctor tells us, the doctor is God. Yeah? Okay? So I do what the doctor tells me. And therefore, if the doctor doesn't tell me, or it doesn't work, or whatever, then I give up. Others that I work with, for me, yeah, I am more 3 and 5. Yeah, challenge me, definitely. Ask questions, yeah, to encourage me to think about solutions around it.
Well, that's the issue, there's no time. A GP will default to prescriptive because there isn't enough time.
Sometimes. So for us, yeah, the key is, okay, how can we do this to encourage them to move around? And this is only one model, by the way. Yeah, there's lots of other models, that consultation models. But how, therefore, can we get them to recognise that actually they've got choice by using some simple skills within what they're doing to make that difference, to be able to switch and recognise. So kind of what I thought that we'd do is to get utilising this as an example to look at, okay, what can you utilise and how can we teach and encourage clinicians to utilise different things that are NLP or clean language based within their consultation to enable them to have that ability to be able to switch. And by the way, I know some people will kind of say, well, which one are you using, NLP or clean language? For us, they kind of really, really integrate so well. They just enable a different way of questioning. So that's when we teach, we kind of bring both things together. So if we look at prescriptive, for example, we look and teach them actually the importance of rapport and how you need to meet that patient or wherever they are, and how you can use rapport skills to make a real difference for them actually taking notice of that advice that you're giving them. How, to step back and go, hang on a minute, is that what they're looking for? Are they looking for my advice? Is that what they're really, really looking for? We talk about speaking the same language. Yeah, we teach them about getting the clues for the type of language to utilise, whether you need to utilise the kinesthetic language, visual language, etc. And we also look at, okay, why is that person not taking your advice? Why is that person continuously coming back? You'll give them a prescription and you'll tell them what to do, and they might do it for 2 days, but they'll still come back and say, Doc, I've still got this problem. And then you talk to them and you say, so did you take the prescription? Did you do what we discussed? Oh, no, because. There'll always be a because. Yeah. I didn't have time to do that, or they didn't, the tablets didn't actually agree with me. I found I had side effects, whatever. What was going on? How to know when a yes is a yes? Yeah, any of you that, both when you work within clinical, but also think about your own personal situations, sometimes when somebody goes, when you're giving advice and they go, yeah, you're right. I've got a friend that does that. When we have a conversation on the phone, I always know that that's the end of the conversation. When he goes, yeah, Joe, you're right. Actually, that's the time to stop, because he's not saying, yeah, you're right. He's actually going, yeah, please shut up. Yeah. So understanding when the yes is actually a yes, and they're going to take that on board. How do you do that? How do you utilise your sensory acuity skills to really understand what's going on and calibrate and understand what's going on? How do you look for clues within what's going on? And how do you understand different maps? So within the prescriptive side of things, that's just some of the things that we teach to allow them to recognise, okay, how do I make this more effective? And also, if that's their preferred style. As we said, there's nothing necessary to say that each of those styles are wrong. It depends on the individual, and it depends on them. If I suddenly start trying to teach a clinician who is very much prescriptive and they've worked as a clinician for 30 years, and that is their preference, and I go, no. You've got to start teaching catalytic way of doing it. Are they likely to kind of do that, or do it naturally, or make a real difference? No, it needs to be within their preferred style as well. within informative, one of the key things is that we teach the real power of using metaphors for the patient to be able to get it and take it on board. So I know for you this is one of your real passions in terms of what you do.
In lower limb medicine, there's a phenomenon called diabetic peripheral neuropathy. I'm not sure if anybody's heard of it. And it's actually quite a difficult thing if anybody has it. Because on one hand, we're telling these patients, I've done this assessment, and you know what? Your feet are numb, your lower limb is numb. Yet we're telling them, but yeah, you might get pain. So in a way to them, it can feel like, well, hang on. You're telling me my nerves have died and my feet are numb, and on the other hand, you're telling me that they're going to be painful, so that doesn't make sense. And often we can, sort of, as a medical team, we can sort of go into the yes and the receptors are not working. We can go into very much clinical spiel. So I recognise the fact that some of the consultations were not quite effective as they could do, and so I've taken some of the metaphor work and I sort of built it in, thinking, how can I have discussions about complex medical things and actually really learn to speak the language that will make sense, and really try to understand what's going on for them, what have they understood, because that's half the thing, isn't it? What do you know, and what do I know, and what do I know you need to know what I know, and it's trying to get that to work. So I was explaining to Joe as well, so a couple of things that I do is actually use props, and I found them to be really, really useful. The diabetic peripheral neuropathy, like I said, I have conversations with them, I use quite a lot of clean language to get their understanding of where they're at with it. And then from that, the majority of people realise that the nerves in your feet are like messengers. So then I'll probably bring out a wire or whatever it is, and we'll talk about wires as nerves in the body. And I use this opportunity to sort of explain the medical stuff, but in a real practical and real way. So for instance, I'll say, so well, what's the job of a wire? They'll say, well, it's pass messages. So what can happen if this end of the wire is not working? Well, it won't pass a message, will it? And what will happen if the message doesn't get passed? Well, the message doesn't get passed, well, then that means that, well, you know, messages don't get passed. I said, okay, well, if that happened in my foot, and, you know, and there's a piece of glass here, and then I went, would that message come here? They'd go, well, actually, no, the message wouldn't get to the brain, Raki. I was like, no, it wouldn't, would it? And then what would happen? And they say, well, you'd be walking around with glass in your foot and you wouldn't even feel it. I'm like, yeah. So then I would sort of bring it back to them. Okay, well, so then, you know, that's what's happening with you, that the nerves are not working. So then, well, what's stripping the wire then? What's stripping the wire? I don't know, what's stripping the wire? So, well, what damages a wire? And then sort of like, oh, is it like from chemicals or something? They say, yeah. So, well, but then what's in the blood that maybe doesn't need to be in the blood? And we'll go, oh, well, is it the sugar? Is it my sugars are a little bit high? Or what do you think? They're like, oh, yeah, well, maybe that's what it is. Maybe that's what's stripping the wire. Therefore, the wire's not working. Therefore, I've got this numbness. Ah. And the R's will keep coming through. And then peripheral neuropathy, which is actually quite a technical thing, actually becomes about a wire and the stripping of a wire. And then, when they're on board with what the diagnosis is and they actually understand it, when we talk about treatment, it makes more sense. When I say to them, okay, so what we're going to try and do is, so with neuropathy, when you get like, if you've got the wire stripped and a particular part of it gets irritated, you can get short-circuiting, which you can feel as sort of shooting pains. But we can tone that down. We can just let that, it happens, but we're able to do stuff to tone that down. And then when I talk about treatment, and I explain to my clients, what it does is that little patch where the wires got stripped, what it does, it just kind of keeps it a bit quiet. Ah, well, that makes sense. So then the diagnosis would make sense and the treatment makes sense. And I do the same with, I've got some elastic bands, and so skin is something that I have to talk about, quite a lot, because it's quite an important thing when you're talking about the healing of the body. And so I always keep a sort of a bit of an older, sort of dried elastic band and a fresh one. And I'll go, what's the difference? And then we'll talk about this is new, this is old, this is dry, this is stretchy, this can't take a lot of pressure, this can take a lot of pressure. If I stretch this too much, it's going to break. Well, how's that the same as your skin? So just by using the metaphors, they're able to now connect all the dots themselves. I've not gone and give them a lecture about what skin is and what neuropathy is, and I've not told them. They've made the connections themselves, for themselves, and then they themselves all like, well, I've got to be careful with those high heel shoes. Yeah, right, okay. Well, then those trainers maybe I'm wearing, which are pretty good actually, maybe I should wear them a bit more. Already they're a step ahead of what they need to do based on what we've talked about. I'm quite lucky in where I work, and we're not far from the M1 motorway, and that is really useful for me. So I can talk about circulation using the motorway, and then the A roads, and then the B roads, and then the little roads, and then the little dirt tracks, and then my corridor, and what can get through, and what causes blockages, and what is a big blockage on the M1, what's going to happen, and what is a big blockage on A406, what happens. And we can talk about stuff, we can talk about medical things in a real familiar yet useful manner, and I'm just, so metaphors for me has made these discussions that we have just so much more easier, and it's a pleasure to have these discussions now rather than dread them.
So, just a couple of minutes for you to kind of consider in pairs, what difference do you think, using more metaphors, and some of you probably already do it, and knowing some of you are NLP trained, most of you are NLP trained, but if you were able to, what difference does metaphor make to patients taking ownership of their own outcome?
Could I just raise something? You put up the very first thing was rapport, and I think that's a really important one. I would all agree with that. But I don't think it starts with a clinician. I think it starts as soon as you get towards the environment, whether that's front of house or reception.
Absolutely.
And I think that that saves time for a clinician to have to rebuild it. So you give that good example where you phoned up after the admin team. You had to build the relationship again, because actually that lady must have been frustrated because every time, and I think that's a key bit to reduce time for a clinician who's got limited time.
Yeah, I totally agree with you. At the moment, what we're doing today is that we're just looking at that taking ownership and within the consultation, within the 90-minute slot that we've got. A lot of what we also do is that we come in and we do the total solution-based approach for the healthcare organisation, whether that's the GP surgery, community hospital, or outside of that, because a lot of this is about teaching rapport, teaching communication skills to everybody. For a quick example, we did a huge project at Braintree Community Hospital where we taught everybody, cleaners, porters, everybody, because everybody was making an impact, and right through to the management, the admin staff, as well as the clinicians I'm working on as well. So, yeah, totally agree. So just a very quick, what difference does metaphors make to patients actually taking ownership of their own health? What do you reckon? From your experience? A couple of minute conversations. Feedback or experience that you think would help the group as a whole in terms of feedback?
I think what she's Raki. Using everyday objects and getting into discussion where they're giving the answer. You're listening the answer from them, therefore they are ready to take ownership of the answer, and therefore they've done something in the process. They haven't just sat there silent while he's lecturing.
We felt that the biggest thing that comes from having a metaphor that they recognise and they can relate to, and that's the chance that you take if a clinician offers their own metaphor, as opposed to saying, what is that like, so that they generate, the patient that generates their own, is that you've immediately got rapport, because they're thinking, their experience is, you get it, you understand what's going on in my body, and so that is more likely to take them along that continuum to ownership of their symptoms.
Yeah.
And if you offer a metaphor that doesn't fit, that they don't get, or actually it doesn't make sense to them, or for some reason has negative associations, then you're going in the other direction. So it's probably better to help them to generate their own.
Yeah.
In some ways.
Yeah, and again, I think that kind of it's very much a depends. But you know what Raki's good at, she's very good at chunking it, utilising the metaphor, and keeping it simple.
Yeah.
Yeah. We can be very tempted to just say too much, particularly about our style is a more informative style. So I think anyone I'll keep that.
To phrase metaphors, at any moment, isn't it, in the patient where disagrees happen straight away, that you know changes that take place, and to get that and to have a story to do that. The problem I have in metaphors is that they aren't that's really what I get about building yourself up and you know, all this kind of stuff. Really telling something, but you can't do it on the hoof unless you're really good, and you need some prepared, and then you've got problems of repeating it.
Yeah, yeah. I think again we'll talk about some of the other things that we teach in terms of being able to do it a little bit more on the hoof as well. Okay, so let's go forward to confronting. Yeah, the confronting their views, their experience, getting them to think about things from a very different way. What do we think the dangers of that are, from what you know, your own experience?
Losing rapport.
Losing rapport. Any others?
Getting quiet or defensive, just not wanting to share.
A lot of people naturally say no.
Yeah, so they go to their default.
Yeah, and then we find other responses as well for looking at it.
And yet, sometimes confronting can absolutely be the right way to go about things. You know, to be that sort of provocative, to depend on, you know, that individual that's in front of you that has been very much thinking in that same way for such a long period of time, that sometimes they need, you know, that shake-up can really, really work. I know you were talking about a particular instance that you had around this whole...
A really interesting one that had a chap got referred to me, and on the referral it was all the details were there, and then somewhere along the line it said neglect. And with inverted commas, and I thought, well, neglect can mean anything really, so I thought, okay. I looked up his records and I noted that consultation after consultation kind of ended in disaster, and the clinician ended up with a little bit of patients very uncoordinated or unmanaged, not willing to talk, and not person after person was saying they're not listening, they're not paying attention, and it was just, I thought, oh, hang on, this person seems to be getting quite a lot of run-ins with quite a lot of people. So taking your point forward, that whoever's now in my waiting room, I'm already thinking, okay, well, so much's already been done, who am I picking up now? So one of the things I've learned from NLP is about the presupposition, about how whatever's going on, for them, it's positive intention behind whatever behaviour that person has. Is a positive intention. So I read all the consultations. I knew he'd had bust-ups with people left, right and centre, you know, things had been stormed off, and I don't think any fights had happened, but I mean sometimes it sounded like we were holding an essays or maths, and I was thinking, right, okay, so Raki, you know, really, you know, I've got to keep this one in the head. So I went to the waiting room, went to collect him, and the man pretty much looking like this, really dishevelled, his hair was everywhere, his clothes were everywhere, and you could see how the neglect label had been stuck on him. You could really see it. It was just, you know, and you think, well, yeah, gotcha. I was aware, though, what happened beforehand, and I was also aware that he'd been labelled as neglect. And I thought, hang on, no, I'm not going to go down that avenue, and I'm not going to take that sort of label for him. And therefore, my behaviour towards him was very, very different. And I expect maybe that the people before me had read the notes before them and thought, right, well, this chap's clearly not going to listen, so I'm going to really have to give it to him, I'm going to confront him. And I didn't do that one. And I just spoke to him and listened to him and spoke to him and listened to him. It took a little bit of time, but I was aware of that because the new patient had a bit more time arranged in my clinical slot. And we got a few layers deep, so using clean language and a little bit of a bits and pieces, so we got a few layers deep. And then he sort of, his manner changed with me. Because he came in and you could clearly tell he's like, yeah, you're going to give me the same rubbish that everybody else gives me. It was clearly like, it was yeah, I want to hear it. He was chewing gum and sort of attitude. And then he started sort of like, it was as if he wanted to engage with me more. He started sitting a bit more upright in his chair, and his eye contact with me got a little bit better. I think this is what Joe said about sensitive acuity and some of the training we've had. Watch for the small little things. If I'm staring at a computer or staring at my notes or doing stuff, that's not going to, make me alert to a sensitive acuity. So I watched him and how his manner changed with me massively. And I thought, okay, well, something's going on here. And then he started talking about his mum. And that's when it gave me some signs that something about his mum was quite important here. So, just sort of bringing it to the point that what had actually happened, his mum had also been diagnosed with diabetes. And somewhere along the line, he'd seen his mum do something to her feet and ended up with the wound. And then he remembers how she had a dressing on her foot, and this dressing was there for a long, long time. And then he remembers this dressing got bigger and bigger up her leg. And then he remembers how, they were talking about cutting off her foot. And then they did cut off her foot, and then it was cutting off her leg, and then they did cut off what's called below knee amputation, which is probably the next level up on the foot. And then after a below knee amputation, there was an above knee amputation, which is the next level up. And then after that, she died. So what he had connected up in his head was, I do this, it equals this. Therefore, I'm just not going to do that. I'm just not going to do it because in my head, that equals that. And then when he told me, it was if he went, I've said it now. And it really sticks with me because it's one of the patients that I wrote down, and it warmed me up to know that, this is what's going on for this chap. He's not neglecting, he's not a neglect. He doesn't need to have these arguments with people at all. He has something that's connected within him that I know isn't probably true. But what's really nice for me is that, because I've got the clinical background as well, I was able to break down all the pieces for him. So I know what it takes and what needs to happen on a timeline for somebody to end up with an amputation. I'm quite lucky, I work with the team and we've got a really good amputation rate, the lowest in the country. So I'm very, very aware that the formula needed to have an amputation is quite a few bits. So I was able to say that to him, I was able to reassure him, say, you know what, you're in the best place, okay? Second thing, I've just done this circulation assessment, right? So therefore, to have an amputation, this is what needs to happen, and you are about here. And he went, oh. And then we talked about the nerve situation, then we talked about deformities, and then we talked about a few pieces that I know are very, very important to cause an amputation. So you up your risk or you reduce your risk. And I was able to break it down. So I spoke to Joe about it, and then one of the things I didn't realise I did, but which is quite nice because I think Joe gave me this understanding that I was able to help him do was to dissociate from him, look at it from a different perspective, and then apply it to himself. Then at the end of it, you realise that actually this doesn't equal that. And so I could have actually on that day gone with the fact that all these people have made a mess and consequently I'll go down the same avenue. But at the time it felt right to actually confront it, but confront it in the right way, rather than reinforcing those walls, really big, helping him make them more concrete and titanium and steel, and I was able to just sort of break them down slowly. And it was, for me, it's been one of the sort of really inspirational things that I've done. Even after I did it, I was thinking, whoa. And he was just of a different character. When he left my room, it was very different. And that was really rewarding for me, to know that something that sat with him for such a long amount of time has really probably affected lots of his life. He's able to A, tell somebody, but B, get some help and support in a manner that's obviously worked for him. So there's dangers of confronting, done in the right way, I do feel that it can be done.
Yeah, and I think, you know, just some of the areas that we look at around the whole confronting is the importance of using the meta model and clean language, yeah, and also hierarchy. You know, the whole, those of you who are kind of really listening and analysing, Raki's chunking constantly, yeah, in her own language, and that's what she's doing. She's chunking it, she's making it easier for her own thinking in order to be able to work a solution, yeah, with that patient, and also she's using her language to be able to chunk them. But the real, you know, one of the key things, this is why we're really passionate about bringing clean language and NLP language together, is that when you're confronting, it can be, I suppose, tempting to your ego can come into play with it. So utilising clean keeps you out of it. For those of you that have clean language, that's one of the key things on clean language, keeps your stuff out of it, but to be able to confront the thinking in a safe way. And also from a complete state of curiosity.
I think that's a really important point, because confronting is both ways, isn't it? And the patient comes in possibly having gone through Dr. Google. The clinician is affronted because they're the professional expert, and so it's a battering, and you know, it's who wins. And the sad thing is that still happens today, and I experienced it. I used the wrong word, I used a medical terminology, and I got slated. And it was for the fact that you know, I can step away from it, know that I was still going to get the treatment for my son, but it was an interesting one. And he sat there between me and this clinician. And when this clinician walked off, he said, "What's all that about?" I said, "Don't worry about it." But it was a real awkward situation. But it was confronting both ways. And you know, at one point, I thought, "Do I? Don't I?" But it's something I think clinicians and you know, being open to what they're saying and not taking it personally.
Yeah, absolutely. And you know, I'm going to, interest of time as well, at the end we kind of want to show you a video the patient gave us permission to show, where we kind of how simple this is. You can use it in 10 minutes, so I am conscious of time. I'm going to move forward on a couple of the other ones, you know, the whole cathartic style. Well, a big thing of that is identifying what's going on for that patient. What beliefs are they holding? They're keeping them stuck. What beliefs are you holding as a clinician, yeah, that's keeping you stuck in the way of working, that's holding you back? It might be about your own skills and ability, or it might be about that patient that's sitting in front of you as well. We talked about the danger of giving them a metaphor. We're looking about the cathartic style. How do you utilise the metaphor that they give you, in order for them to recognise that a change needs to take place? You had one.
Yeah.
Really.
So I had a type 2 newly diagnosed chap that came to me, and so I thought, he saw how he was getting on, and the first thing he kind of like is, well, it's all right, yeah. But like I said, when is a yes a real yes, and to recognise it's not a real yes, that is. So, well, you know, how are things getting on? Oh, you know, I just feel stuck. Okay, so how do you mean you feel stuck? You know, as we went into what stuck is, and then he came up with this metaphor about it. It's like you're in a traffic jam. It's like I'm in a traffic jam. Okay, so when you are in a traffic jam, you know, what happens and how do you move forward? And if I'm having this discussion about this, him being in a traffic jam, or what happens in a traffic jam, or what's going on in this traffic jam, and then he brought his own solution to it. Well, I just need to reroute, don't I just need to reroute. Yeah, that's what you do, you just reroute. I thought, okay, well, so to me, we were just talking about traffic jam and reroute, but then towards the end of the consultation, it was to do about Coke. And all this was about Coke and changing Coke and Coca-Cola. Coca-Cola. It was about the Coca-Cola element of it. So it was interesting how he gave me this metaphor, and we worked through it. He's clearly taken advice for himself from it, and going from rerouting, and he's already applied it to himself. Well, that's what I'm going to do.
So he's recognised his own choices and different routes that he can take those. You know, sometimes it's like they don't even give you what the problem is, first of all. Yeah, but working with the metaphor can be so cathartic. So we kind of teach and encourage. Very interesting as well. When we say teach, our teaching is slightly different. We work with the clinician for the clinician to get their own answer to what they need to do as well. The other thing is, you know, how can around the whole self-realisation, how to give yourself advice. You know, we all know that the most effective advice is the advice that you give yourself. So how do you utilise what we know within NLP and clean language in order for them to give themselves advice? One of my favourite ones was your lady that talked about her mum, etc.
So I'm quite lucky. I also work at a rehab hospital, and so I see people from that perspective as well. And the lady was in for some rehabilitation, which needed just a review of her lower limb. So I did the reviews. So what I know from rehab, you need to be a little bit, right, okay, so I'm going to get this, right, okay, so you need to be a little bit like that. So I've done all the assessments, I'm thinking, you're doing really well, you know, you're doing up there, you know. And she's like, yeah. So I recognised actually something's not quite right here. She's not quite in the sort of resourceful state I'd like her to be in. So I said to her, explored it a little bit more with them and sort of used some clean language questions. And what was happening was that she'd come into hospital, and a couple of people have ended up saying to her, I think you're losing your memory. I think you're losing your memory. So she started to take on this, I'm losing my memory. But knowing her medical background, knowing what happened to her, there was no reason why she should be taking this on, and maybe something she's just forgot to do, and then it's become something it hasn't. And I thought, well, it's probably not a good place to be. So I thought, okay, well, what can I do to help her? So I said to her, oh, so Margaret, tell me, what was happening for you when you were 7 years old? She went, oh, 7 years old. She went, oh, wow, Racky, when I was 7 years old. And then she started telling me about how it was during the war, and, you know, bombings were happening, and this was happening, and that was happening. But she goes, but you know what, Racky? She goes, we made a bit of a game of it. And I went, oh, okay. And her manners changed, her mannerism changed. She became this really, and yeah, what we used to do was, right, we used to do this, we used to do that, and her personality changed very much as well. I said, Margaret, tell me this. I said, if your 7-year-old self was here today, okay, so this, you know, all this 7-year self, what would that 7-year-old you tell you now? And she went, oh, what would my 7-year-old tell me now? Well, I'll tell you what my 7-year-old tell me, Racky. I'll tell you what she'd tell me. Just bloody well get on with it, she'd say. Stop messing around, don't be so scared, you know, you've been through the war, what can be worse? You know, and her advice to herself was just so lovely to see, that how her 7-year-old self was able to give her advice. So she started telling herself, oh God, yeah. And I said, all that exists, doesn't it, Margaret? And she went, you're right, Racky, maybe my memory isn't going actually. And then she started laughing, and it turned to a bit of a joke. And what was interesting for me, that earlier on she used the word wobbly. And I don't know what wobbly means, it was a word that she used, wobbly. And so after the 7-year-old advice had given her the advice, she went, and there's no need to be wobbly about going in the stairs and going in the garden and taking those steps. Be strong about it, just do it. Don't be so wobbly about it, just do it. And it was lovely to see the Margaret before we had this discussion about the 7-year-old, and the Margaret after we had the 7-year-old, because it was helping her, for me, it was helping her recognise those resources exist at her deeper level, but just bringing them to the surface and giving herself advice. And I don't know what wobbly was applying to it all. It was a garden, and it was the step, taking the step into her garden.
The thing is, though, that Racky couldn't have done any of that, and I'm sure that having all, you know, good clinicians, you're all good listeners. Think about it from a GP perspective, okay? By the way, some of you might know this, anybody, the study they did at Harvard, anybody know the average time from the moment a patient sits down in front of a GP before the GP starts talking and giving their opinion? What do we reckon?
30 seconds.
30 seconds. Yeah. It's 19. Yeah. And yet who's got the information? Yeah, the patient. The thing is, think about it from a GP perspective. Just GPs, there's lots of different clinicians around, but obviously let's just think about GP 10 minutes. Life has changed within the NHS. Most of them don't have their own list, so patient walking through the door, they're lucky if they've got a relationship with that patient and know their history. But in that 10 minutes, they've got to find the history, they've got to find actually what symptoms are, they've got to do their diagnosis, they've got to give the prescription advice, whatever that is. So it's how much is going on in their own head, and how risky is it they're going to miss information. So, it's going to be working with what the situation is, but recognising the different styles of listening, how many times they can listen completely distracted, how many times they're listening, depending on their preferred style, to want to come in and give their own advice. So we talk to the clinicians about this and teach them different ways, as you do fantastically, in terms of being able to improve their listening as well, and the importance of that. In terms of the catalytic, it's okay, what does clean language actually really do? Well, it enables space, it enables what's underneath that surface, so that they can take ownership. The patient can actually take ownership and develop a solution in the way that Raki just described in that one example. And also, we look at how important it is to know the drivers, to know the values behind the change as well. We look at the dangers of people holding things at identity level. I'm a diabetic. It's part of who they are. Actually, it's not. You can categorise it in a number of different ways if we look at neurological levels, but is it a behaviour? It's the way your body is behaving. Is it a skill? Yeah, what is it? Is it just something you live with? Is it more an environmental thing? But it's not who you are. Exactly. They do it and they live it. And looking at that, sometimes that's because of the way they were given the diagnosis. So therefore that label. And the clinician will just naturally use those labels in their own language. Yeah? Not for, often subconsciously just using those labels, but recognising the dangers that those labels actually have. We look at why telling the other person their value doesn't work. We know that stuff. You guys know that stuff. We look at just meta programs. Why? Somebody's externally motivated, great, they might like it, but if they've got an internal motivation driver, you telling them that you're valued and everything you're doing is so good, they're not going to click. You'll then just notice whether that nod is a nod, real nod, or whether it's. So we look at all of that as well. And utilising clean feedback. Any of you who knows about the clean feedback model? Okay, it would be really tempting when you see something being done well, or you want to give someone feedback. You kind of want to go, the old sandwich feedback, let's go with a great thing first, and then let's go with the poo, as I like to call it, and then we'll go with a nice bit of bread on the outside of it. But very often we'll give an emotional feedback, and use emotional words, or a very top level. You're doing really well. We look at the other side, that really upset me. The problem with that is that people will either not get any learning, what does doing really well actually mean? What am I giving them to actually utilise there and learn within it? Or I'm hitting them with an emotion, what are they going to come back with to me? An emotion. So the clean feedback model looks at the actual evidence, first of all. What actually happened? What are you doing? What have you seen? What have you heard, first of all? Then it looks at, and expresses that. Then it looks at your mind read, because remember, you can only mind read, you don't actually know. So what are you mind reading from that? So we look at it from a clinical. So, so I've noticed that you've been back to see me for, 3 times, and on each of those 3 times, I've given you a different prescription, but, there's you've not been able to continue to take that medication. So my inference around that is whatever, the impact of that on your health, because the second stage we look at is the third stage we look at is the impact, and that's the clean feedback model. And then you look at what would make the difference around that. So we teach that model and how you can really utilise it within a healthcare environment as well. I want to give you just one example of how you can bring this together. So this was working with Yasmin, the doctor that I originally said. And this was actually, so this is how you can use it. This was the first time she brought the skills together in a consultation. And Keith, the patient here, has given us full permission to utilise this in a training environment. It's interesting, isn't it? Yeah, he knew the stuff to do. He'd been to all the diet and exercise guy. He'd done everything. What was underlying? You know, that's I think the other thing is it's about less is more. How much did the clinician actually say? It was purely questioning and getting him to come to his own solutions. So that's the kind of thing for us that we teach and why we're really passionate about it. I'm really aware of time. We're going to get chapped out of the room, and you guys are probably really hungry. Please come and talk to us on the stand if you've got any questions, or talk to us in the room, whether it's Raki or myself. We actually have Stephen at the back as well. Stephen's a GP. You'll notice we gave you some information about an advanced communication skills for clinicians course that we're running. Stephen's also running that with Raki and myself. If you've got anybody that you think, you know what, you guys all work in the health environment, you notice that there's people around you think, you know what, it would also really help them to learn these skills, please pass that information on. We are so passionate about it. For those of you that have done your NLP practitioner training and you kind of want to learn, okay, how can I use the linguistic side of things to really be able to do some of the stuff I know I can do, there's also the advanced linguistic course, so please, if you want to talk to us about that, we would love to see you. Thank you so much, guys. Hopefully that was helpful.